very hot topic, which is MASLD. What is this MASLD? Actually, it's baffled by MASLD. We'll see what it is. First of all, I want to talk about two stories of two of my patients whom were treated by me and my trainers at Ragama Hospital, Ragama University. This is the case. There are two stories. One is she is 54-year-old lady presented with fever for 3 days with severe arthralgia, myalgia, and headache. So this problem was not responded to paracetamol. So she thought of doing a full blood count, and it showed low platelet and low blood, WBC. So she admitted to the hospital and started dengue monitoring. But the appetite reduced, but regained within 2 to 3 days. Symptoms gradually reduced, not developed any features of leaking or like difficulty in breathing or abdominal distension. Her past history was significant for diabetes mellitus for last 5 years, but other than that, she didn't have any uh, uh, comorbidities which causing this low platelet and low WBC. Her family history also insignificant for hematological diseases. Past surgical history also not significant. In case of case two, it's the gentleman, 65-year-old gentleman. With he came with chronic body itching for last 2 years, mainly over lower limbs, below both knees. First, it was started after. Recording in progress. Hello, can you hear me?
Yes, doctor, we can hear you.
All right. Sorry for that. Now, when this itching was started, first he was worked in the Middle East as a healthcare assistant. Wanted to wear long stockings. So he thought, he attributed this itching due to the contact dermatitis caused by long stockings. But even after stopping using these stockings also, this itching persisted. But no other rashes we could appreciate. But excoriated lesions over both legs were there. No recent weight loss or altered bowel habits. His past medical history was significant for dyslipidemia for more than 15 years. Other than that, he has had benign prostate.
Excuse me, Prabhat. Hello, Prabhat. Hello, Prabhat. Can you hear me? Hello.
Madam, we can hear you, madam.
Now, what you have to do is, even Prabhat or whoever, could you please mute all people like mics, because it's very disturbing. Don't disturb the speaker, because you cannot concentrate on things. Please mute. I think that Prabhat can do all. Could please all the mics. Except finance, you can talk.
Yes, madam. Thank you. Then the rest of the history is like this. In the case of drug history, they have not taken any medications such as cytotoxic or Ayurvedic treatments or liver impairment drug like is also statins. This lady is a teetotaler and non-smoker and no sexual promiscuity. In case of this gentleman also, he has not taken any long-term drugs other than tamsulosin and atorvastatin. And he is also a social drinker but non-smoker. He follows monogamy. From this history, on examination, what I found was their BMI is little higher. It is 25.97 in case that lady, and not pale, not icteric. Some xanthelasma present around both eyes, but no palm erythema or no other peripheral stigmata of liver disease. But small, smiling ankle edema was there. In case of CVS, it was normal, 140 by 90, pulse rate of 104. Abdomen, CNS, and respiratory systems were normal. In case 2, he was little bit pale, not icteric, some scratch marks over upper limb and abdomen, depigmented multiple skin lesions over bilateral lower limb. No other stigmata of chronic liver disease could be appreciated. Other systems were normal. These are their case 1. You can appreciate some features of dermopathy on this lady. It shows the long-term impaired glucose, impaired glycemic control. In this man, these depigmented patches could be due to the long inflammatory process causing post-inflammatory depigmentation. We'll see what were the causes for this. What do you think? What could be the culprit for this problem? My friends talk now. Hello? Now one has come with low platelet, another one presented with chronic body itching. Hello?
Is it due to a liver condition, finance?
Yes, could be. What else?
Hematological malignancies like leukemia?
Could be good. Yeah, this itching, usually the leukemia patients present with like this type of pictures. What else? What are the things comes to your mind?
Hemolysis also can cause?
Hemolysis. If so, there could be other stigmata, isn't it?
Like
Icterus and
icterus and all.
yeah, yeah.
Renal
Okay.
disease?
Yes, itching, yeah. Uremia can cause. This man could be having an evaluated kidney disease. Could be.
SLA?
In whom? Lady or male? Male one.
Lady?
Could be. Yeah, low platelet they are presenting with. But this is, oh yeah, the age is not matter, no, 54. Usually SLE will present more than earlier, no? But
Autoimmune
still,
hepatitis, finance?
yes, of course.
Autoimmune hepatitis.
Yeah. Okay. Okay, we'll see what autoimmune diseases, chronic hepatitis B, C, we have to think because now we are in such a country, so we have to think of infective causes as well. And hemochromatosis also, even though these people are in elderly, we have to think of them. Another thing is non-alcoholic steatohepatitis. Other things, this DILI means drug-induced liver injuries. These are the culprit drugs. NSAIDs, herbal medications, statins, anti-epileptics, illicit drug use. So we have to ask in the history. And Wilson disease. Wilson disease also, they might present a little bit early, but still we have to think of. Congestive cardiac failure, they should be come lower down because their other features not uh, um, showing cardiac failure. Other we have to think is endocrine diseases like hypothyroidism, hyperthyroidism, and Addison's. Then let's see what our patient has. These are the investigation findings. This lady, she was admitted in the hospital and they have done the serial blood counts because they have they have did the dengue monitoring. So her platelet was 61, 51, 74. But last one was 56 on the fourth, fifth day. So they think of discharging her because there is a small rise. And ask her still NS1 negative, dengue antibody, IgM, IgG both negative. They discharge this lady and ask her to come back with the full blood count in 1 week. In case of this chronic itching gentleman, his full blood count shows normochromic, normocytic anemia, like 10.3 HP. And other parameters were normal on him. And UFR also didn't show any significance. In blood picture, in the lady with low platelet showed thrombocytopenia, which was attributed to virally induced thrombocytopenia. No MAHA. So hematologists suggest CRP monitoring and monitor platelet count if thrombocytopenia persists. Refer to hematologist. So even after we did the full blood count again, we'll see what has happened. But in case of chronic itchy gentleman, his blood picture showed normochromic, normocytic red blood cells, but no abnormal cells found in his blood picture. This is their liver profile. What are the abnormalities in this liver profile? Hello? Hello? Right, okay. You can see the albumin level of this case 1 is reduced. Globulin is in normal range, but SGOT-PT, what has happened? SGOT increase, alkaline phosphatase also increase, gamma GT also increase. Some liver cell damage has happened. We'll see why it happened, maybe due to the dengue itself or other reason. In case of case 2, his liver enzymes also derange. gamma GT 81, SGPT 50, SGOT 57, alkaline phosphatase, it was in normal range, and albumin globulin also in normal range. Their lipid profile were normal because both of them, in lady, because she was taking statins for hypercholesterolemia. This gentleman, even though he has taken atorvastatin, the optimum level was not achieved. So, in order to find a cause for these disease conditions, we did some investigation to find out the problem they faced. Their INR was little increased. It was 1.38. HbA1c was 7.43. Creatinine normal. Hepatitis screening was done. It was normal. A, B, C, all were normal. In case of case 2, INR also nearly normal. Hepatitis A, B surface antigen negative, hepatitis C also negative. Because of the chronic itching, we did serum ferritin to rule out what it's hemochromatosis. TSH, I did to rule out hypothyroidism, which can cause chronic itching. But still, we couldn't find a cause because serum ferritin 655, not due to the hemochromatosis. If it is due to hemochromatosis, it should be more than 1,000. This could be due to serum ferritin is increased due to metabolic syndromes. 1 week later, this first lady who was treated for dengue came with this report. Are you happy with this report? Hello? Right. You can appreciate this platelet count. It's still low in lower side, 68, and current sequent one also 59. But WBC count, it's 6.2. It was little increased than that acute phase, in which the WBC count was very much reduced to 1.4. Then we were wondering what could be the reason for this prolonged low platelet, long-standing low platelet. So ultimately, we think of doing ultrasound scan of abdomen. These are the
නවත්තලා වාගේ බුඩුසම් හරි මැක්ස් හරි කරන්න.
in case 1, unfortunately, her ultrasound scan showed cirrhosis complicated by portal hypertension. No ascites, no evidence of hepatocellular carcinoma. Very pathetic because up to that level, up to the dengue fever, she was very well active and did all the household things and followed a very average lifestyle. But now she presented with cirrhosis complicated by portal hypertension. In case 2, early parenchymal liver disease with mild splenomegaly. Both of these cases were not identified earlier. So as primary care physicians, It's our duty. This where this miss was happening, because all the patient with comorbidities like diabetes or hypertension or liver disease, dyslipidemia, all should be screened for liver enzyme derangement. Uh, you will understand why is this during my lecture. During the evaluation, in the absence of secondary causes of chronic liver disease, we calculated the FIB4 calculation. In case 1, it was 14.43. In case 2, it's 3.62. Both of them were referred because our cutoff point is 2.6. So both of were, it shows the fibrosis. So we have to take the hepatologist or specialist opinion for further management. So both of them were referred to hepatology unit at Ragam. These were the things done on them. In case of case 1, they have done upper GI endoscopy because at that time she was already established liver cirrhosis. So we have to uh, rule out any portal varices or other things. So in this case, she shows she has small esophageal varices, but no fundal or cardiac varices. Portal hypertensive gastropathy was there. But in case of case 2, they have done a fibroscan. I'll explain what is fibroscan later, because it is done to measure the fibrosis in the liver of people. It shows 7.6. Their cutoff is 8. If it is more than 8, they will do interventions. But if this is 7, less than 7.6, they ask to follow the dietary and lifestyle modification and repeat the fibroscan in 2 years. This is what happened to my patients. Just to recap your knowledge on liver disease, non-alcoholic liver disease, NAFL, some question or 2 question is there. We'll see what it is. And a 40-year-old patient present with increased fatigue for last year. Her history is significant for obesity. The patient is currently not taking any medications. The patient denies smoking, alcohol, or any other illicit drug. Vital signs are temperature, heart rate, blood pressure were in normal range, with respiratory rate was with 10. Laboratory results are hemoglobin 11, WBC 600, platelet 320, but AST 160, ALT 100, ALP 70, bilirubin 0.8, hepatitis panel negative, iron panel negative, liver biopsy performed. What is the most likely finding? Hello? Hello? Prabha? Others' mics were muted. Oh, they can talk.
They can talk.
Right. What could be the answer? Okay, I will tell the answer. Here now, what has happened? Everything is normal other than the liver functional derangement, but no secondary causes of liver derangement found. In case of that, microvascular steatosis could be appreciated in the liver biopsy. Another one, or this is the last one, 66-year-old female with the past history of hypertension, type 2 diabetes mellitus, hyperlipidemia, present for a regular follow-up. The patient has an established diagnosis of non-alcoholic steatohepatitis related cirrhosis. What is the most common cause of mortality in NASH-related cirrhosis?
C. Cardiovascular.
Very good, very good. Because this is the reason we are so much of worry, because the people with NASH and NAFLD, they are dying not merely due to the hepatic diseases. They have very much high risk of cardiovascular mortality. Okay, now we'll move into the topic. These are the topics I plan to discuss with you. Right, we'll see what is the definition of NAFLD or MASLD. New nomenclature is MASLD. I'll tell how it differs from the MAFLD. Now, there are so many definitions. Fatty liver disease secondary to metabolic dysfunction. Another one is hepatic manifestation of metabolic syndrome. The other one is hepatic expression of adiposopathy. So, however, this is the definition in histological definition is more than or equal to 5% of hepatocyte display macrovascular steatosis in the absence of readily identified alternative causes of steatosis, which are medication, starvation, monogenic disorders like hemochromatosis or Wilson disease, in individuals who drink little or no alcohol. That means for female, it's less than 20 grams per day. For male, it's less than 30 grams per day. This is the definition, right? Then I'll tell you what is the difference between this NAFLD and MAFLD. What is this NAFLD? NAFLD is liver injury causing absence of any secondary causes of hepatosis, steatosis, or excessive alcohol consumption. All the people who develop has steatosis, we call MAFLD. But if they have these risk factors of metabolic risk factors, they will categorize as MASLD. MASLD, according to the above criteria, in conjunction with at least one of the 5 cardiometabolic risk factors. Can you understand the difference now?
Yes, we can.
Okay. These are the cardiometabolic risk factors. There are main subgroups, 5 subgroups. At least one, if a patient has, we can categorize them as MASLD. One is BMI subgroup, another, second one, diabetes subgroup, third one, hypertension subgroup, fourth one, triglyceride subgroup, fifth one, HDL subgroup. In that also, BMI subgroup, if a patient who is more than 24 BMI, we can categorize them to the risk factor, or else their waist circumference is more than 80 for female, more than 90 for male. In the diabetes subgroup, this is unfortunately, this pre-diabetic also categorized into the cardiometabolic risk factor. So if a patient's fasting blood sugar is more than 100 or ppb is more than 140 or HbA1c more than 5.7, and a patient with diabetes or patient on treatment of diabetes, they also have this cardiometabolic risk factor. What is this hypertensive subgroup? That is, if one's blood pressure is more than 130/80, on hypertensive, they are categorized to cardiometabolic risk factor. In HDL subgroup, HDL in male, if it is less than 40, or female, if it is less than 50, or patients with lipid lowering drugs, they also categorize to having cardiometabolic risk factor. Likewise, in triglyceride also, if their level is more than 150 or on lipid lowering drugs, we can categorize as cardiometabolic risk factor. What is this now? In new nomenclature, there are so many names. So we will find out what it is, even though it's not so much important to us. As primary care physicians, we have to know uh, to which category your patient is belongs. So if a patient with cardiometabolic risk factor and without any secondary causes of steatosis, we can categorize as MASLD. But if the patient who has cardiometabolic risk factor and they are consuming some moderate amount of alcohol, they are categorized to MASLD. And other group is the people without cardiometabolic risk factors, but they are having secondary causes like alcohol or drug induced liver injury. They are called specific steatotic liver disease. Other group who have no risk factors or no cardiometabolic risk factors, they can categorize to cryptogenic steatotic liver disease. We'll see what is the epidemiology in our country. This, why do you think when we go to a medical ward, every day we can find a patient with liver disease? But what is the cause for this increased incidence of liver disease? Actually, now it's like a pandemic. Okay. Increased prevalence of obesity and increased prevalence of metabolic comorbidity diseases like insulin resistance, dyslipidemia, central obesity. These are the culprits to developing NASH or NAFL. Global prevalence is in 2022, it's 32%, but unfortunately in Southeast Asia, it's more than 40%. In Sri Lankan study, there are few studies. In 2019, in Ragama Health study, they found that 32.6% of NAFL. But still it's more than the global prevalence. This is how this non-alcoholic liver disease progresses to the cirrhosis. Normally, first there is a steatosis, then it follows the steatohepatitis with first fat deposition, and mild inflammation. Then this mild inflammation progressed to hepatocellular injury, including fibrosis. But not all, only 44%. Out of these, only 20% they will develop bridging fibrosis and nodule formation. So ultimately they develop cirrhosis. The important thing is to this cause to happen, it will take 20 to 25 years. So primary care physician, you have ample time to diagnose these patients at any time. I tell at any time we have our role to play. This is how the fibrosis categorized, fibrosis 1, 2, 3. Uh, this is the other causes of liver disease. And another important thing is not only the metabolic derangement, lean body mass, people with lean body mass also can develop MASLD by hypertension, dyslipidemia, uh, improper control of hypertension and dyslipidemia and diabetes. This is the natural history. First, people develop steatosis, and out of that, only 20 to 40% they will develop steatohepatitis. That this hierarchy can go without, these people can die without developing advanced fibrosis. Why it is this? They will have high mortality, cardiovascular mortality. The problem with them is the adipose tissue, the adipose in our body, adipose tissues are not functioning capable with NAFL. So the fatty acids are deposit around the hepatocytes. So, and fatty acids are liberate to the blood circulations as well. So, this lipolysis, lipolyzed fatty acid causes inflammation in the vessels, and they can cause atherosclerotic plaques, and thereby they can increase the cardiovascular event. This is the main point we have to consider, because the people with MASLD or NASH, they are dying not only due to the cirrhosis, but mainly due to the cardiovascular events and non-hepatic malignancies. Now, normally, 5% can progress to advanced fibrosis. Out of that, 50% go into cirrhosis, and 7% ultimately go into hepatocellular carcinoma. What are the treatments? Actually, FDA up to the year 2023, FDA not approved any medications, but now in the current studies, they have developed some drugs. I'll discuss about them, but main thing is not the drug, but the lifestyle modification. This should be managed by multidisciplinary team. One is hepatologist, endocrinologist, physical and rehabilitation doctors. I think we are included in this category, and dietitian and the psychologist. We need all of their care to manage our patients. So now in treating this patient, our target is to prevent the progression of liver disease by modifying metabolic risk factors that improve cardiovascular disease and cancer. Main prognostic factor is fibrosis severity. Most aspired endpoint, fibrosis reversal to prevent extrahepatic cardiovascular outcome. Currently, no drug approved for the treatment of MASLD, but management of adiposopathy and optimizing comorbidities like diabetes, hypertension, dyslipidemia, MASLD occur when adipose tissue capacity is surpasses by surplus energy. That means high energy content, high energy intake directly affect on this muscle. So low calorie diet is the main uh, uh, it can play a main role. Decrease adipose tissue burden, improve its function. We'll see this weight loss, how it affects. This is evidence-based among persons with a MASLD. Weight loss of 5% of total body weight can reduce the hepatic steatosis. But if you lose your body weight more than 7%, you can improve the NASH. That means second stage. Not only that, this is very marvelous thing. You can, in our faculties, we have, what we were taught is this fibrosis cannot be reversed. But here, the weight loss more than 10% can reverse the fibrosis. Fibrosis regression can be achieved. So, my friends, you can see how how can we help our patient prevent advanced liver disease. This is what the schematic diagram which shows there is a study with sustained weight loss over 1 year, NASH resolution, fibrosis reversal of 45%, NASH resolution so to 64 to 90%, and ballooning and inflammation. It's in the earlier stages, they are 100% can be reversed. And steatosis also 100% can be 35 to 100%. So the weight loss, weight loss, weight loss. It's a very big, it has a very big role to play. Management of adiposopathy, what can we do? Lifestyle intervention, bariatric surgery, endoscopic bariatric intervention, and this is nowadays all are talking about weight loss drugs. What are these drugs? GLP-1 receptor agonist. It's liraglutide. In scale study, it promotes 60 to 80% weight loss with 3 gram daily. And in the lead study, it induced resolution of steatohepatitis 39% and lower the progression of fibrosis 9%. So this liraglutide is a marvelous drug. At the same time, this semaglutide, even though they are expensive, if a patient can afford, still it's very beneficial. In the STEP study, it promotes, they have found that it promotes 12% of weight loss with 2.4 milligram weekly. And it improves diabetes, hypertension, dyslipidemia by 25%. And it improves major cardiac events as well. There are other drugs, vitamin E and pioglitazone. They can be used in specific circumstances. And FDA approval has given for these drugs in special circumstances. At the same time, you can use SGLT2 inhibitors to reduce uh, the weight and reduce steatosis in the hepatocytes. And there are 5 drugs. They are in the now uh, uh, coming to the market, and they have taken the approval as well. One is obeticholic acid. Some of you have heard about this, but another one is semaglutide, which I discussed earlier. Other 3 are they increase the hepatic lipid sensitivity. So thereby they prevent the hepatic steatosis. And this is the drugs which should be taken by the patients with liver disease. I want to highlight this red meat. It should be taken less than 2 portions per week because it can promote steatosis. At the same time, you have to promote vegetables and fruits every day, more than 2 portions per day, like, and physical activity. Physical activity, as in the other circumstance, we have to promote at least 30 minutes per day or 150 minutes per week. This is the lifestyle approach to the MASLD. Physical activity, as I mentioned earlier. And another interesting thing is coffee consumption. There are studies which show it will promote regression of steatosis. Even though now we are not promoting coffee among patients with cardiovascular risk factors, but it's important for the patient with liver disease. And this calorie energy restriction, as I told earlier, calorie should be taken between 5,000 to 1,000 per day. And other thing is alcohol. But now the safe limit business is not there. If you started or if you have hepatic liver disease, you have to completely abstain from alcohol. And this fructose intake, which causes fatty acid deposition in the blood. So we have to avoid fructose containing food. What is the role of primary care physician in the evaluation of liver disease? In primary care, what we can do is we can assess their liver functions during their clinic visits at least once a year. And thereby we can screen for the MASLD. And this Fibrosis score, it's a very good score which can rule in or rule out the fibrosis. Others are very, it's difficult to do it to each and every patient, liver biopsy and this transient elastography. Actually, what transient elastography is the fibroscan. It is available, I think, in the hepatology unit at Ragama. They are doing free of charge, but in other places we can't take that opportunity to do. Right. We see this for how it helps us to find out the fibrosis. This non-invasive test in the evaluation and management of patient with MASLD. There are 3 main tests. One is FIB-4 index. Other one is NAFLD fibrosis And the other one is platelet aspartate transfer aminotransferase to platelet ratio. Out of three, FIB4 is the most validated one. So calculated, it can be calculated using age, AST, ALT, and platelet count. So FIB4 is recommended as a first-line assessment for practitioners like us based on its simplicity and the low cost. This is how the FIB4 is calculated. If FIB4 is 1.3, they have low risk. If the FIB4 is more than 2.6, the fibrosis is ruled in. So we have to offer them specialized care with the hepatologist. Patient is in the intermediate zone, that means FIB4 score is between 1.3 and 2.6. We have to follow them up by doing fibrous scan and other determinants. This is how the patient with intermediate risk are evaluated. Other thing is what we can do, how our primary care is play a role is we can optimize their diabetes, hypertension, and dyslipidemia. In case of diabetes, we can use pioglitazone, GLP-1, and SGLT2 agonist inhibitors in managing their glucose level. And in case of hypertension, you must consider this. You can start ACEI and ARB as first-line treatment for the low-risk patients and intermediate risk patients. But if a patient has developed cirrhosis, you can't use this ARB or ACEI inhibitors because they are in the verge of decompensation. So they will have hepatorenal shutdown and renin angiotensin activation will be there. When you use this ACEI, the picture will be deranged more and more. So we have to withhold ACEI and ARB if the patient has cirrhosis. Dyslipidemia also, there is an interesting point. Now we all try to use statins on patient with liver disease, but there are so many studies have done. These statins are very good to patient with liver disease because they can prevent atherosclerotic heart events. If the patient is for the first time, if they are not inducing hepatic enzymes, we can safely use these statins up to decompensated cirrhosis. But if there is a decompensation, it's better to stop statins. But still, there are some studies. Those statins still beneficial effects are there in the decompensated cirrhosis as well. And we have to use higher dose with high potency statins if their LDL levels are high. This is now I'm going to finish my discussion. These are my references. Do you have any question to be clarified? Hello? Hello, Prabha.
Oh, Sainath, we can hear you.
Right. Indrila, do you have any question?
Well,
There
not
are
that much,
two questions
Sainath.
in the chat box, ne?
Madam?
There are two questions in the chat box. Isn't it fine, asked?
Sorry, madam, I didn't see. Okay. In lean bodies, MASLD patient does controlling the comorbidities, for example, hypertension and dyslipidemia, lead to reversal of steroids, of course. They can, even they have lean bodies, sometimes their abdominal visceral fats could be there. They can have, more and more exercises, and by that they can control their hypertension and dyslipidemia to reverse this steatosis. Hasara?
Yes, fine. Thank you.
Okay. Mm,
So,
yes, we can't promote weight loss in them, you know. So we have to promote physical activity on them to reduce the risk.
Finance, you said that SGL2 inhibitors for the weight loss. Is it for the
Yes.
diabetic patients or even non-diabetic patients can be prescribed for the weight reduction?
Yeah, a very less amount. There are studies they have been done, just not just for weight reduction. There are some, it reduces the steatosis in the hepatocyte as well. But is it Lakmal? Lakmal, purely weight reduction, I have to read about it. But in patient with diabetes
Shall I
and
add?
yes,
Hello.
madam.
Thing is now the SGLT2 inhibitors is a marvelous medication. Of course, it is not actually it came to the world not to manage diabetes. It is to
Yes.
the like sort of a management of the cardiac heart failure, right? So the advantages are not only the reduction of weight, the blood pressure, everything, the CO2, everything. Lipid profile will give deranged lipid profile will be back to normal. The hypertension, all the risk factors will be normal, and the weight will be normal, and everything. So because they like sodium and as well as glucose. So the co-transport of these blocks, and what happens is all the things will be like passing from the body. So the less sodium and less sugar level in the body. So it sort of converts all the it's not converts actually. It's sort of rearrange the system, and it gives very unexpected benefits. So I think SGLT2 is a marvelous medication, though there are like myths of having UTIs and all the things, but all the new studies proved there are no such things with the SGLT2 inhibitors. Only thing, so you cannot give it for the people who are like dehydrated, elderly who are not getting adequate amount of liquids, because with that, like you pass a lot of sugars, and ultimately what happens is with sodium, that may be more dehydration and higher risk of getting strokes. So because of, other than that, it's a very good one. And liraglutide, I think there are a lot of things with the liraglutide we discuss at the in our clinic. I think Manoj, you can contribute what a liraglutide help, how it helps, even for the diabetes. For the we discuss about the not pre-diabetic. We are not telling now pre-diabetic. We say it's sort of a impaired fasting glucose or the beta cell organ, not the failure, it's a dysfunction state. So how the dysfunction state, how the liraglutide help or the GLP-1 analogs helps. Manoj, could you please talk about that?
Yes,
And
madam,
all-
there's new research evidence that in pre-diabetes, patients with pre-diabetes, that
diabetes things now is impaired or the
yeah,
failures,
in fact, yeah,
dysfunction.
that Langerhans whether although there are dysfunction of Langerhans cells, there's some evidence to suggest that ductal cells of the pancreas can
And-
secrete insulin.
So by giving liraglutide, so you can convert those things as a secreting like cells, is it?
Yes.
So that's how, but that is how the other some countries now they actually they are in a sort of a, not in the research level. Now there is a implementation. They have already started that. They implemented it. The people who have this dysfunction state, people or maybe impaired fasting glucose, they give a huge sort of a weight reduction, the lifestyle modification plus this liraglutide. So then you also mentioned about this, the how it helps for the reduction of the fat in the liver cells. So it's more or less similar. So what ultimately the cause for the diabetes is also the same. So it comes from the same source. So it's part and parcel. It's a very good, actually, it's a very good, it's, of course, the people, but the very first time, it's difficult to absorb if it's the very first time. I think if it's available in the web, like in few days, so you can go, go through at maybe several times, then you can get. And one more question. So if you have a patient with like NAFLD or MAFLD, how you assess whether the patient is deteriorating? What are the ways you can investigate? What are the measures or the data you can gather from the patients if the indicative of the deterioration of the condition?
Madam, we can calculate the FIB4 score.
Yeah, FIB4 score at the beginning, of course, we have to do. After that,
Yes.
how do you do that? Any ways of
Ultrasound, sorry, madam, they have to undergo biannual upper GI endoscopy
yes.
to find out the portal vein.
So at the beginning, of course, you grade it, right? This is the way.
Yes.
So now you have to check whether they go into the good part, the good side or the bad side,
Yes.
right? So are there any indicators for the patients day to day? How you measure? What are the indicators? So in maybe follow-up clinics, what we are supposed to do?
Madam, good control of comorbidities.
Yeah, but with the good control, definitely it will go back to the normal stage. So what are the indicators? Because in the fibrosis, of course, we don't keep the patients. No, it's a duty
Yes.
of the the hepatologist or whoever they're there. So
Yes.
for that,
HbA1c,
ALT-AST, madam?
huh?
ALT-AST?
Yeah, it's okay. It's a LTST levels. What else?
Platelet
HbA1c,
count.
They do the platelet count as well. It's very
Yes,
simple.
madam. Mhm.
Simple. Right, so this is how we have to do, but it's a very good and very marvelous, as I mentioned earlier. Also, it's very good, and it's the we have chosen a good good case scenarios. You never think this is, of course, a liver disease. That should be the way you have to find. Okay, so in those cases where you find this type of, you don't think it's a sort of infection or some sort of a as we day to day we see like dengue or whatever. There are other things as well. A good eye opener for you all. Thank you very much for your wonderful presentation, Finance.
Thank you. And thank you, my colleagues, for your patience listening. Thank you so much, madam. You were there to me for to arrange my discussion and presentations and helping to organize the slides and all. Thank you
Okay.
so much.
Right, okay, it's my pleasure to help you all the time. Anyway, so the next time, I don't know, I think we have to give the chance to the most juniors as well, I suppose now. It's a high
Yes,
time. Is it? It's a high
yes,
time.
madam.
So just check whether that I think the year two registrars also didn't do only one person did, I suppose. Yes.
Some of them have done, madam.
No. In this particular forum, the Friday one.
Yes, madam. I
Good.
think headache, no, it's not headache, heel pain and breast,
Heel pain, who did heel pain?
heel pain did,
Yeah,
Sachin, no? Sachin.
Sachit did heel pain.
yes, madam.
That's okay, Sachit did. And then I think only he
No,
did.
madam, some cardio, ischemic heart disease one have done.
No, not in this particular forum, not the forum, because it's the Friday ones in the sense like the one I conducting this thing, of course, in no, not that, no, only the one I think only one chance. I think for the Sachit, of course, did I suppose, because they are separate ones, so not like this. They during their appointments, when they do a presentation, they like present. So that is of course different from the usual Friday classes, every other day Friday classes. So I don't know, it's up to you all to decide who will be the next person. Anyway, so find a good be an article or a case or some sort of a differentials and whatever. It should be related to the primary care. And it should be like eye-opener, like the way we like today discussed. Okay, it's good.
Thank you.
So do you didn't ask any? So they didn't ask any questions, Finance. Either they didn't understand or they understood very well. Why no questions today? Otherwise, usually there are a lot of questions. Okay, I keep my mouth shut, so you better discuss.
Hello? Do you have any questions? Oh, feel sleepy.
Fine, As. Thank you very much for your
Yes.
nice presentation. I have one question like,
Yeah, Indraland,
yeah,
tell me.
as earlier we discussed like fatty liver, again,
Yeah.
non-alcohol fatty liver, but I
Yes.
think the nomenclature has changed now
Yeah.
because fatty liver doesn't reflect the pathogenesis and pathology of the disease. So now the world
Yeah.
has agreed upon a new nomenclature. Did you come
Yes.
across and can you
Yeah, that is MASLD. Yeah,
find it?
I'll show MASLD and the other one is there. It's MET-ALD. MET-ALD is the patient with moderate alcohol consumption and wait.
All the definitions are there, I suppose, in the particular diagram.
Yes. There are so many nomenclatures due to the new study, the Delphi study, I think. You can. This is interlap. Here, these
yeah,
are the new
okay.
nomenclatures. MASLD, ALD, and cryptogenic SLD, and other specific etiologies with SLD.
Okay, fine. But it looks complicating, right?
Yeah, very complicated. But we have to digest this. We have to
No,
identify who are the.
not complicating. First of all, the very first two, yes or no. The first thing is does the patient meet any cardiometabolic criteria? So that is the first thing you have to understand.
Yeah. Okay,
Then
madam.
only you can go down, go down and see where your patient is. But I think better, anybody, the registrars, better get a sort of a, I think print out and keep it with you, or
Yeah.
else in the phone or whatever.
Okay. Okay, fine. Got it. Thank you.
Okay, Indra.
Finance, there's another question. I
Yes.
have, maybe you have described this earlier, but I had some connection problems. So when we get the ultrasound scan report, it says grade 1 fatty liver, grade 2, grade 3.
Gayatri, now it's a very common problem we have, but this normal scan cannot mention about this fatty liver. Madam, do you agree with it?
Finance, when I did my radiology, what I realized is they
Yes.
compare with the capsule of the liver and the density of the liver. By comparing that, they grade it. But it's with, yeah. Now we have advanced fibrotic scan, so it
Yes.
will replace it.
We can't say for sure, Gayatri. We can tell there is fibrosis, fatty liver, but we can't mention about the stage of fibrosis on them without fibrosis score or fibroscan.
Okay.
I couldn't get the question. I was in something else. Like, could you please repeat the question?
Madam, I was asking, when we take a ultrasound scan report, it
Yeah.
says grade 1 fatty liver, grade 2 fatty liver, grade 3 fatty liver. What does indicate
Yeah,
like?
that is the thing, right? So as I think Indra gave you the answer. So
Yes,
as comparing with the thickness. So it's not so much indicative like what we expect now. So it's normally what they do is just to have some sort of an idea. Is there any problem with the liver? So if you are very sort of, because if we just say ultrasound scan abdomen, so their concentration, not only one organ, the whole the abdomen. So then if we get some sort of fatty liver, maybe either 1 or 2 or 3, with the rest of the findings we have as clinicians, so then we can sort of find the most suitable investigation, either imaging or whatever. So we cannot expect the radiologist to give the whole picture, what we have in our mind.
Yeah.
Right? So then they can give some rough idea. That's why I'm always telling, I think you can remember, when we request, we have to give a good, sort of a history in the paper. Right?
Yes.
So that say, this is what we are expecting. So query this, like what. So then have a little bit, we guide them what they are supposed to do. But still, the machines they have, it's not so, I mean, the good ones. So if we really want to see the one particular organ, so then we have to choose what imaging we used to choose, not the normal ultrasound scan then.
Yes, madam.
Yeah, I think that should be the answer for that, I suppose. Just give some sort of a guide where to go like.
Yes, madam. Thank you.
Okay. If they don't have any questions, we'll wind up then.
Thank you so much for everyone.
Good night.
For
Thank you.
Thank you very much. Good night.
Good night.